Good morning, ladies and gentlemen. Uh, so while we were, planning this postgraduate course and discussing, so the theme was what is new in hepatology. MASLD nomenclature, we thought, everybody knows about that diagram and everything. So what was new in this MASLD nomenclature, we thought was this new entity which has come up as MASLD. So next, 14, 15 minutes, what I'll do is, we thought that this may be very important for the postgraduates to learn about this new entity called MASLD. But this is one area where, we would still need focus for next, few years, and a lot of research and the data obviously needs to be generated for this. So I bring greetings to all of you from PGI Chandigarh. So I think we all understand the change in the nomenclature of fatty liver disease which has happened in last year or so. 1980 to 2000, we know this was all NAFLD, and then briefly came the MAFLD 20 to 23, and then 2023, the Delphi consensus came in, and this became MASLD, and now we have more than 70 societies across the globe who have endorsed MASLD as the nomenclature. But the good part which has happened is this. This is our own data. We have a consortium in India called Indian Consortium on MASLD, ICOMD, and we have now close to around 9,000 patients in this consortium. But this data, we just analyzed to see that the previous NAFLD, how is it different from the present MASLD? So you can see there are more than 7,500 patients. So majority of the patients, maybe 98% of our patients with MASLD actually qualified, even with the newer definition of MASLD, which means that most of them actually had one or the other metabolic dysfunction to be called as MASLD. So they were similar. So this is, not only, Dr. Lumba, can we request you to be on the dais here? So this is, this is true not only from our Indian cohort, but if you see data from US, from other Europe and all, that also says that MASLD and NAFLD is almost the same. So which means there being a significant overlap between NAFLD and MASLD. So there was an apprehension when this nomenclature got changed that do we need to repeat all these studies on epidemiology, clinical profile, diagnosis, natural history, and treatment on MASLD also again, since the nomenclature has changed. But with such a similarity between the two, I think we don't need to do that. And all the data which was there for NAFLD is also applicable to MASLD as well. But then, within this nomenclature, and I'll show you the diagram, this new entity came in. This is a MASLD. So where we do not really have data because this entity came with this change in this nomenclature. So that's why I think we probably need to refine, understand this entity more, and we need to have more data on this particular entity. And most of the studies which I'll show you now in my presentation on the definition, epidemiology, its clinical profile, severity assessment, natural history treatment, that's all come in last 1 year. So you would see all the references would be on 2024. Because as I said, this is a new entity which has emerged from this diagram, which you will see more often now in next 2-3 days and during this meeting. This is, umbrella term which has been now given by this Delphi consensus. This is called steatotic liver disease, SLD. Within this, I'll show you data. The major component remains what we call the MASLD. MASLD means that you have on imaging or on histology, you just heard Professor Lumba on this, that just steatosis and one of the metabolic dysfunction. So one means these are all 5 components of metabolic syndrome, so-called the cardiometabolic criteria. So if you have one out of these and on imaging or histology if it shows you fat, this becomes MASLD. And the severe form of this becomes MASH. But on the other extreme, you have patients with alcohol-related liver disease, you have drug-induced steatosis, you have genetic causes or other hep C-related steatosis. So there are other causes like this. But then in between, in real life or in in real life world, what we see is that many patients, those who have MASLD, could also be consuming some amount of alcohol. So the cutoffs for MASLD are typically are less than 20 gram per day for females and less than 30 gram per day for males. And for ALD, we know that it's more than 50 gram for females and more than 60 grams per day for males. But now how about those who are taking alcohol in between, which means females having metabolic dysfunction, fatty liver on imaging, but also consuming 20 to 50 grams of alcohol per day, or a male consuming between 30 to 60 grams of alcohol per day. So that is what has been defined as MASLD with increased alcohol intake or a moderate amount of alcohol intake as MAT-ALD, which can also be MASLD predominant if the alcohol is not much, or if it's on the other extreme, it can be ALD predominant. So I think this is what we are discussing today. As I said, in real life, somebody has MASLD, but also consumes this moderate amount of alcohol, which is not typically fitting into either ALD or not fitting into MASLD. You are in between there, and this is known as MAT-ALD. So this is the definition. But also, at least in our part of the country, and I think many centers across the country, we do see another entity called where patients have full-blown alcohol-related liver disease, but they also have metabolic dysfunction. We also know that alcohol induces so many metabolic abnormalities. Many of our patients with ALD are obese, they are diabetic, they are dyslipidemic. So, this is another entity which has not been addressed very well in this, Delphi consensus, but then, this is a group which probably is the severest form of, within the ALD group also. This is another one. So let's get into it. When this entity came in, the MAT-ALD entity came in, most of the centers, they started analyzing their data to see that where does, this fits into. This was one of the first studies which came from the UK Biobank, and this is minded, these are journal population data. Journal population data, which, people were coming for journal checkup, and they were all recording their alcohol consumption. They had undergone MR scans and MR-PDFF, and the steatotic liver disease defined by more than 5% fat in their liver. 11,000 patients in total out of these 40,000. So the prevalence of steatotic liver disease was close to 27%, which we do understand that the fatty liver disease is close to around 30% in the community. So within that, as I said, the major component was MASLD. 85% is MASLD. 10% or 11% is MAT-ALD, and only 1% is ALD. As I said, this is the journal population data coming for journal checkup. Within that, if you see patient with fatty liver, majority, 85% will turn out to be MASLD. A small fraction, 10-11% will be MAT-ALD, and a very small fraction would be ALD. So similar data, came from other centers, but before that, this study also looked at the differences between the MAT-ALD and the MASLD. So if you find it here, see the differences between MAT-ALD and MASLD, what they found was that the BMI was slightly more in the MASLD group. There were more males in the MAT-ALD group, but the cardiometabolic risk factors were more in the MASLD group, which looks again understandable. But when they looked at their biochemical differences between the two, the enzyme elevation, both AST-ALT and gamma-GT, was happening more in the MAT-ALD group. But again, if you look at the profile on the HbA1c, HDL, and triglyceride abnormalities, that was happening more in the MASLD group. This is understandable, but as I said, since there was no data, this was the first study which tried to look at the differences between the MAT-ALD, MASLD, and came out with these differences. Then came another Korean study. This is again a journal population data of close to around 3,500 patients. All have undergone MR elastography and MR PDFF. And again, if you look at this, the steatotic liver disease amongst this journal population is close to around 40%, which is again, as I said, 30-40% will have fatty liver. Of these patients with SLD, majority again is MASLD, 75% is MASLD. 20% is MAT-ALD and 1% is ALD. So, the figures are almost the same. In general population data, as I said, 70 to 80% or 85% MASLD, 10-20% is MAT-ALD, and the least is ALD. But this study also looked at their, severity based on the MR elastography. And if you look at the figures here, the values in kilopascals of MR elastography, the ALD and MET ALD are almost same, but MASLD is less, thereby suggesting that probably the patients with MET ALD, their severity will go more towards ALD, and they are little more severe or higher fibrosis in comparison to the MASLD group. The next question comes in after the magnitude and the kind of severity they have. How good are the non-invasive tests? We heard an elegant talk by Professor Luma in the oration in the morning. So how good are the non-invasive tests for MET-ALD? MASLD, we have a huge data. So how good are these for MET-ALD? And the commonest parameter we use is FIB-4. So how good is, say, for example, FIB-4 or MR elastography? So in this particular study, which is again a Korean study, again, a very large number of health checkup, patients underwent MRE. So what they said was they took cutoff for advanced fibrosis as MRE as more than 3.6 kilopascal. And then they started looking at the utility of FIB-4 in identifying these patients with MRE value more than 3.6. And they found that the FIB-4 was actually had a very good sensitivity and specificity and a good diagnostic performance in picking up this kind of advanced fibrosis even in MET-ALD, to the extent that the diagnostic utility of FIB-4 in picking up these patients with advanced fibrosis, which is MRE value more than 3.6, was similar in MASLD and MET-ALD. So FIB-4 was performing same in MET-ALD and in MASLD. So again, which means that probably the same biomarkers could also be used for MET-ALD. Now, final question comes is that how do these patients behave on long term? MET-ALD. As I said, there's a very limited data. The data has come up only last year, but this is again one of the data. Dr. Alexander Craig is sitting here. This is from their center, the Galaxy Consortium, where they had taken these 446 patients with history of alcohol intake, little more than 24 grams for women and 36 grams for men. And then they divided these patients based on their alcohol intake within last 3 months into groups like MASLD, MET-ALD, and ALD. And then they had a follow-up from 2018 to 22. And then they saw how many had decompensation, how many had mortality. And what they found was that the risk of decompensation was highest in ALD, followed by MET-ALD, and least in MASLD, which also, so which actually means that severity of MET-ALD is almost similar to ALD maybe, but and the decompensation is highest in ALD, followed by MET-ALD and least in. And if you look at the mortality figures from this paper, again it is highest in ALD, then MET-ALD, and least in MASLD. So I think again that depends, which means that the severity of MET-ALD is in between MASLD and the ALD. This is another paper which is enhanced data. Again, a large number of patients. Final inclusions were around 8,000 patients, divided into 3 groups. Then they retrospectively had this follow-up of 26 years. 2,500 patients died. But this is very important here. In comparison to those who had no steatosis, non-MASLD steatosis, the risk was not really high for mortality risk. But MASLD, it went up, but it went up further with MET-ALD, and the highest risk for mortality was ALD with metabolic dysfunction, which I said is a very severe group. You have ALD also and a metabolic, full-blown ALD and metabolic dysfunction. So finally, coming to the management in these patients would require an integrated approach, management of both your alcohol use disorder, AUD, and their metabolic dysfunction. So I think there's a need for integrated clinics like AUD clinic and metabolic clinics. And we are lucky to have these 2 clinics at our center. So I think we need to give them, comprehensive approach to these patients. In addition to managing their metabolic dysfunction, we need to manage their AUD. But one important data which I would like to mention here is the role of GLP-1 agonist, which is coming in. So GLP-1 agonist, and this is one study on semaglutide, which has shown that this has an anti-craving effect, and people had less of recurrence of alcohol or incidence of alcohol use on sema, which means that SEMA can help you not only for your metabolic dysfunction, but also for your alcohol use disorder. So I think we would need more studies or data on this. So my take-home messages for postgraduates would be, so if you look at the prevalence of all the SLDs, the prevalence of MAT-ALD is close to around maybe 7 to 10%. More males, higher proportion of patients having higher liver enzymes, and the higher fibrosis in comparison to MASLD may be same as ALD. FIF4 and MRE are as good in MASLD, in MAT-ALD as in MASLD. But if you look at their natural history, the risk of decompensation is higher in MAT-ALD in comparison to MASLD, and there's a higher mortality in MAT-ALD in comparison to MASLD. Management would require an integrated approach, and probably we would need some drugs which are active against both. But I think probably we need, a little more understanding, more data, because, all this data on alcohol intake is based on history, on your recall. And all these cutoffs of 20 gram, 50 gram, these are all arbitrary. So I think we probably need to revise them, look at, what that's very, very important. This could be dynamic. Today somebody could be no alcohol, tomorrow he could be MAT-ALD, day later he could fit into ALD. So these are all dynamic process. And then whether the drugs which are effective against MASLD, whether they would have equal efficacy in MAT-ALD group, we don't know. So I think all these are the areas of future research. So thank you very much for your kind attention. We'll be happy to take